everyone, and welcome back to Pharmacology with Dr. Sokolow. So this is the last lecture on pharmacokinetic. After this one, we'll move on to pharmacodynamic. But first, I still have several pharmacokinetic parameters that I have to cover with you in order to understand the time course of the drug response. So in the previous one, we talked about half-life, and now we're going to talk about apparent volume of distribution and clearance. These three parameters are related to each other, and it's going to help you understand better the time course of drug response. So first of all, let's do a little review of the body compartment. We have the total body water represent 50 to 60% of the body weight in an adult. So if it's an adult that weighs 60 kilos, it's about 36 liters. And this water compartment include the intracellular fluid, the plasma, the extracellular fluid, the interstitial fluid, and the transcellular fluid. And then you have 20% of fat. Now, when we talk about the apparent volume of distribution, it is not a real volume, but it's a reflection on how the drug will distribute through the body depending on several physicochemical properties like the charge, the solubility, is it lipid soluble, water soluble, the size of the molecule. And this volume of distribution is equal of the total amount of the drug in the body divided by the concentration of the drug in the plasma. So if you remember from the previous lecture, I said that the plasma concentration is going to reflect the intensity of the response of the drug. And so here, depending on how much drug we have in the plasma, so if it's well distributed, this volume of distribution is going to be low. Now, if you have a drug that tends to accumulate in another compartment than the plasma, so let's say if you have a highly lipophilic drug that is going to cross the blood-brain barrier and spend time in the brain, that means you're going to have more drugs in the brain than in the plasma. And in that condition, because the numerator is higher than the denominator, when you divide a huge number by a small number, the product is a high number, so high volume of distribution. For a drug that is well distributed in the plasma, that means this denominator is going to be high, and the numerator is going to be low. So if you have a small number divided by a high number, the product is going to be a low number, so a small volume of distribution. So the volume of distribution can exceed the volume in the body. And why? Because it is the volume apparently necessary to contain the amount of drug homogeneously at concentration found in the plasma. So if it's not homogeneous, you're going to have more drug in another compartment than in the plasma. So the drug with a high volume of distribution have higher concentration in the extravascular tissue than in the plasma, and they are not homogeneously distributed. And then drugs that completely retain within the vascular compartment and have a minimum possible volume of distribution, which is equal basically to the blood component in which they are distributed. So these are the drugs that are well distributed. So the volume of distribution reflects if a drug binds preferentially to tissue at the expense of the plasma. So as I explained, a highly polyphilic drug can concentrate in the brain if it's, like an antidepressant, for example. Therefore, the concentration of the drug in the plasma is extremely low, and I'm going to have a huge apparent volume of distribution. And if the drug accumulates outside the plasma compartment, that's when the volume of distribution can exceed the total body volume. Now, the next pharmacokinetic parameter that I want to cover is the clearance. So the clearance measures the ability of the body to eliminate the drug. And it's equal of the rate of elimination divided by the drug concentration in the plasma. So you see here If you have a higher concentration in the plasma, your clearance is going to be lower because again, you divide the numerator is divide a denominator that is high. So in most of the case, the drug follow a first order elimination, and that means in that case, the rate of elimination is directly proportional to the drug concentration. Because if you rearrange this equation, you see that the rate of elimination is equal to the clearance multiplied by the plasma concentration right here. And so that means if you give more drug, you have a faster rate of elimination if the drug follows a first order elimination, which is the case of most of the drug. More drug, elimination faster. And so that's why when you reach the plateau and the steady state is because you have more drug in the system and then it's getting eliminated faster. So in that case, you have a constant fraction of the drug in the body that is eliminated by unit of time. So we see the concentration, and this is the rate of clearance. And this part here is the first order elimination. Now, at some point where the enzymes are saturated, you see that if the concentration of the drug increase, you don't see an increase in the clearance. The clearance remains steady. That's when the enzymes are saturated. And that can be the case, in somebody who has an impaired kidney function or impaired liver function. And a good example of this phenomenon is when you drink a shot of tequila, you're fine. You drink 2 shots of tequila, you are fine. You drink 3, then you reach this, the enzyme saturation, and your body doesn't eliminate your tequila at the same rate as it was when you only had 2 shots. So, and now in order to understand how the half-life is calculated, is found, during those pharmacological studies, during those clinical trials. So the half-life depends both on the clearance and the volume of distribution. And you see it's a constant 0.693 multiplied by the volume of distribution divided by the clearance. So which means a drug with a high volume of distribution is going to remain longer in the system and has a long half-life. And a drug that is eliminated faster, that have a high clearance, are going to have a small half-life because, again, you divide by a high number. You don't need to know. I'm not going to question you what is the equation of half-life, what is the equation of volume of distribution, or what is the equation of the clearance, but I want you to understand the principle behind the clearance, the volume of distribution, and the half-life. What is the meaning in terms of pharmacology about all those 3 parameters? Now, we talk about first order kinetic, and you have the 0 order kinetic. So that's when it's a capacity limited elimination. So my example of your shot of tequila, that's what happened. You reach the 0 order saturation when all the enzymes are saturated, and which means if you take another shot, you don't eliminate, and you see the rate of elimination become a constant. It's not dependent on the concentration of the drug anymore. It's just saturated and it remains the same. So here you see from the previous slide, the rate of elimination equal the clearance from the drug, the plasma concentration of the drug. And so for a few drugs, this elimination becomes saturated at high concentration and is independent of the concentration anymore. Example, ethanol, phenytoin, which is an anti-epileptic drug. And that's one you have to monitor in the hospital. Patient on phenytoin, you want to make sure that you don't reach that 0 order saturation, because it can become it can cause adverse effect in the patient if you reach that point. So the zero order is when the rate of elimination and the clearance of the drug is no longer related to the concentration. So the steady state in that case cannot be achieved. The plasma concentration can increase unpredictably if the dose is increased. So again, I think the best way to understand this concept is with alcohol. So you were fine with two, and all of a sudden you take the third shot and you are like passing out because your enzyme is saturated. So the response is unpredictable, and it's unpredictable from one patient to the other, from one student to the other, depending on how many shot of tequila they can um, tolerate. And so, but for the clinical relevance, when you take care of the patient, let's say who's taking phenytoin, you have to be aware that a slight change, a slight increase in that concentration can saturate the enzyme and then can cause adverse effect. And it's especially important when you have a drug that has a narrow therapeutic index. So you remember we talked about therapeutic index, like the therapeutic range, when the minimal effective concentration and the toxic concentration are close to each other. And so if you reach, all of a sudden you saturate the enzyme and the patient can no longer eliminate the drug, and you have such a narrow windows, you can jump and be in the toxic zone. So, and these are some examples you see of a normal kinetic and a saturating kinetic. Here, the drug is given, let's say 10 milligram, and you have several doses that are given, and you see you reach your steady state after 4 to 5 half-life, and if you increase and you give, several doses at 10 milligram, you still have a plateau. You increase the dose to 20 milligram, and you repeat, the dose, the administration, you see the difference is like the plasma concentration start to be higher. So the plateau, you see now you are around 15 micromole per liter with a 20 milligram dosing, but you see you're still predicting the rate in is equal to rate out, and you don't have unexpected jump in the plasma concentration. You increase the dose to 30, and same thing, repeated dose. You see that you reach your plateau after 4 to 5 half-life. What changes is the plasma concentration. Now you are between 50 and 100 with a 30 milligram dose of drug A. And now you give 40 milligram. You still reach your plateau after 4 to 5 half-life. But again, the difference is the plasma concentration on the y-axis. So you see that now you are above 100 micromole per liter. That's for a first order kinetic. Now, if you have a saturating kinetic, if you give 10 milligram repeated dose, you see you have a predictable response because the rate of elimination is still under control. The way in equal the way out. But here you start to saturate the enzyme, and you see with repeated doses that you start seeing an increase. You don't really have the same steady state as you were seeing on the other graph. When you give 20 milligram, you see like the jump. You don't have a plateau. And then with 25, it's even worse once you get repeated doses. And then the last thing that I want to talk about is bioavailability. And this is something that is important when you convert a patient from a parenteral drug to an oral drug. So you have a patient in the hospital that receives the drug parenterally, and then when he's discharged, he's going to have to take the medication per us, so by mouth. And some drugs are highly bioavailable, so that means the IV dose is equal of the oral dose. So that's the proportion of the administered dose in the plasma. So IV dose is assumed to have a 100% bioavailability. And oral bioavailability usually are less than 100 because some are absorbed and metabolized, while when you give the dose, when you inject a drug directly in the bloodstream, you have no barrier of absorption and it's readily available. So here you see when you give the drug by injection, you start, everything is in the system, and then over time you're going to have a reduction of the plasma concentration of the drug. Now, when you give it orally, because you have the absorption, you see that you have an increase in the plasma concentration over time until you reach a plateau. And then once the metabolism and excretion occur, then you start seeing a decrease in the plasma concentration. And so you see that the area under the curve for the parenteral drug versus the enteral drug, you see that the shaded area are different. And so here you see there is a big difference between the area under the curve for the parenteral medication versus the oral medication. It's the same drug, but they have it's the amount that is going to be available for the body when given orally is way smaller than what it was when it was given parenterally. So the bioavailability is the area under the curve for the oral medication divided by the area under the curve for the injected medication multiplied by 100. Again, you don't have to know the equation, but I want you to understand the concept when you say you have a drug that is highly bioavailable versus that is not highly available. That means, there is a difference between the response when it's given parenterally versus when it's given per month. And so now all those parameters summarized in the table, and that's where you're going to have to play and see if you understood what I talked about when I talk about volume of distribution, clearance, bound to the plasma protein, oral availability, how much is excreted in the urine, and half-life. So in green, I highlighted drugs that has, I would say, that are well distributed, that are homogeneously distributed in the body. That means they have a small volume of distribution because they are well distributed in the plasma. And since they are well distributed, you can see that their half-life is pretty small because they are distributed and then metabolized and excreted. No drug that has high volume of distribution, you see that they tend to have a higher half-life. And here fluoxetine, which is Prozac, the volume of distribution is 2,500 and have a half-life of 53 hours, which is more than 2 days. And now when you look at the clearance, so you see that the clearance for aspirin, it's 39 liters per 70 kilos, and volume of distribution 11, and then the half-life. So you can see the connection between the three. Here you have bioavailability, so drug that would be given orally or parenterally. You see the difference. So this one is highly bioavailable, so you don't need to convert when it's switched from IV to oral. But other that has a low bioavailability, they will have to be converted. The dose would have to be converted when you switch from an IV medication to an oral medication. And this is all for pharmacokinetic. I hope you enjoyed, and now we will move on to pharmacodynamic in our next session. Meanwhile, stay well and stay safe. Thank you.